In colloquial language, we often use precision and accuracy interchangeably, but they mean very different things from a statistical standpoint. Precision is the consistency and reproducibility of a test and is also sometimes referred to as reliability, whereas accuracy is a measure of how close test measurements are to true values and is sometimes referred to as validity. A precise test may not be accurate, and an accurate test may not be precise. Let's look at some examples that illustrate this concept. Let's say you're throwing darts at this bullseye. You missed your target, but the average is in the center. So over the course of 6 darts, you have a lot of variation, but the average is on the money. This represents accuracy, but notice there's high variation in the dart locations, and none of them are at the center. Okay, let's try this again with a new handful of darts. You were listening to me and decided, hey, I'm going to make sure I have less variation in my shots. So now your darts are highly clustered, but in the wrong spot. This is high precision, very little variation, but low accuracy because you didn't really hit your target. Actually, you didn't even come close. So now we want to try again. And this time, the darts are tight and centered, which means they're both accurate and precise. This is the goal of any test. Finally, this last diagram shows my attempt at dart throwing. It's wildly scattered and off-center. This is neither accurate nor precise and doesn't bode well for me actually winning any dart games, which is why I don't play darts. Now when we look at random error, this is basically the enemy of precision. It reduces the consistency and reproducibility of a test. So here's your accurate and precise test under the influence of random error. On the other hand, systemic error reduces the accuracy of a test by consistently skewing results in a particular direction and thereby reducing the validity of the test measurements. Okay, time for another practice question. A new rapid and portable salivary glucose meter for diabetics measures a patient's salivary glucose concentration to be 200, 201, and 198 micromolar on 3 independent measurements. Using a gold standard measurement technique, the same saliva sample is determined to have a glucose concentration of 150 micromolar. How would you describe this new test in terms of accuracy, precision, and error? So here the answer is D. This new device was consistent in 3 independent measurements, so it is precise. However, its results are more than 30% higher than the gold standard measurement, which means it's not accurate. A precise but inaccurate test would exhibit significant systematic error. So what might cause systematic error? One source is bias. Bias is a really fun topic to learn about and talk about. Understanding the different types of biases that can occur in a study is moderately high yield and worth reviewing. Bias is defined as the situation in which an outcome is systematically favored over another. It therefore causes systematic error. Let's review this with a quick flash quiz. Do you recall what systematic error reduces? Systematic errors reduce the accuracy of a study. So let's start with bias that can occur when recruiting participants for your study. Selection bias is the non-random assignment of subjects to the study groups. For example, selection bias occurs if only hospitalized patients are used as a control group or if patients themselves decide which group to enter into. Thus, each group is not a representative sample. There are a few more specific examples of selection bias, such as Bergson's bias. This is when you use a study population that is selected from a hospital. Now, clearly, people in a hospital are generally not a healthy population compared to the general population. Another example of a study population that is subject to Bergson's bias is called the healthy worker effect, where people healthier than normal are used for your study. For example, if you're doing an orthopedic study on ACL repairs in competitive athletes. Can you think of another example? Something like loss to follow-up or non-response bias is a common cause of selection bias in many studies. In each of these situations, the patients in each group render the group non-random and thus non-generalizable. Let me try to explain this a little bit with an illustration. Let's say you're running an intensive weight loss and diet program. At the start, you've enrolled a group of people. So here you've enrolled a group of obese people and they're going to be taking your diet and exercise plan. So you make them exercise, you make them diet, but some of these people actually won't make it to the end of your plan. either because they can't maintain the schedule you've had for them, or they don't think that the plan is working, or some other reason. So we're going to put question marks over these people because they're probably not going to finish. Now, at the end of the trial, you've got people who have lost weight effectively, and then you also have some people who probably maintained their weight or maybe even gained weight. However, you've also lost this whole group of people. And so now when you look at your results, you're missing these two data points. Excluding these results influence your results. Now, let's talk about bias that occurs while you're running your study. Recall bias is when the knowledge that a disorder is present affects recall by subjects. For example, if patients are asked about past behaviors like smoking that may have had negative effects such as during pregnancy, the patients may not remember or report these behaviors accurately. Hence, recall bias is common in retrospective studies. Sometimes, if you can catch your population of interest close to the occurrence of events, you can decrease recall bias because your population has less time to mull over their situation and try to make sense of it. Measurement bias happens when information is gathered in a way that distorts it. For example, my GPS on my phone always overestimates the distance I've run, but it keeps time perfectly. The result is that I think I'm running faster miles than I am. The only way to combat this is to standardize the method of data collection. Procedure bias occurs when subjects in different groups are not treated the same. For instance, when more attention is paid to the treatment group leading to greater compliance with treatment. How could this be avoided? Well, by blinding the researchers and doctors administering the treatment. The observer expectancy bias occurs when a researcher's belief in the efficacy of a treatment changes the outcome of the treatment. This is a form of observer bias and can be avoided by having an independent observer interpret experimental outcome. What kind of blinding would this be? This would be an example of a triple-blinded study. Confounding bias occurs with two closely associated factors, when the effect of one factor distorts or confuses the effect of the other. Here, the effects of extraneous factors muddle the exposure-disease relationship. Confounding bias can be prevented by matching controls to cases so that they have all of the same characteristics, or as much as possible, except for the factor, of course, of interest. Lead time bias occurs when early detection is confused with an increase in survival. This type of bias is commonly seen with improved screening. The natural history of the disease is not changed, but early detection makes it appear as though survival is increased. With this type of bias, think about screening tests such as those for cancer. Using placebo, blinding, or crossover studies can aid in decreasing biases. Crossover studies are those in which each subject acts as their own control, meaning that if I have group 1 that receives this pill, which is a treatment, and I have group 2 which receives a placebo, at some point, maybe midway through the study, group 2 would get the treatment and group 1 would get the placebo. That way, people in both group 1 and group 2 have gotten both the treatment as well as the placebo and can then act as their own controls. Many different forms of biases can actually be eliminated in this manner. Randomization is very effective at reducing selection bias and confounding bias, while matching subjects so that the groups being compared only differ by one important parameter is a good way to reduce confounding bias. It can be hard to keep track of so many different types of biases, so let's try an example question. You want to know if heavy alcohol consumption increases the risk of bladder cancer. You conduct a prospective cohort study comparing drinkers to non-drinkers and obtain a relative risk of 2.3 with a p-value of less than 0.01. So are you satisfied that you have demonstrated a causal linkage between drinking and bladder cancer? What type of bias could be at work here? So this is a classic case of confounding bias, since smoking is linked to both the independent variable, drinking, as well as the dependent variable, bladder cancer. In our study, it may explain some or all of the association we've observed between drinking and bladder cancer.